of our department to the 22nd CPC arranged by Brooks Pharma. Before formally starting this program, I would like to give you all a short introduction about our department. Our department was established in 1976 by the legendary Dr. Syed Harun, and because of his contribution in this field, he was also recognized as father of dermatology. He left this department in 1989. After a long gap of 26 years, Dr. Rabia Ghafoor revived teaching and education in this department from 2013. She became HOD and professor in August 2024. It was her efforts that a 5-bed facility is now a 30-bed facility. We have multiple OPDs operating general and specific concerns. We are offering free of cost phototherapy medicines to underprivileged patients, including biologics. Under her supervision, this ward has trained 100 plus trainees, including FCPS, MD, and MCPS. Daily classes, monthly tests, educational seminars, and mocks are conducted to benefit trainees on regular basis. It is the privilege of this department that some of our trainees are now head of department. Today, we will be presenting 3 very interesting cases which are rare in OPD and fit perfectly to the class of grey cases. Let me call our first speaker, Dr. Moksha Devi.
आवाज होते हैं साइलेंट है
Sorry for inconvenience. We are starting now. Good morning, everyone. I'm Dr. Moksha Devi, resident in Dermatology Department, JPMC Karachi. Today, I'm presenting a very interesting case of 38 years old male, married, labor in garment factory with no known comorbid, resident of Maliri, Karachi, admitted via OPD with a chief complaints of thickening of skin of hands and feet for 9 months and thickening of skin of face for 7 months. Now coming to a detail of presenting complaint, my patient was in his usual state of health 9 months back when he noticed gradual thickening of skin starting from hands and feet, which progressed to involve the upper and lower limb, face, neck, and trunk, with sparing of the scalp, axilla, genital region, and mucosa. There was no preceding history of swelling or redness. Gradually, the skin thickening became pronounced over the hands, leading to stiffness of the small joints of both hands, reduced joint mobility, and unable to open the fist. Associated with mild pain in small joints of hands, but no redness, swelling, and morning stiffness, was relieved by analgesics. He noticed reduced facial expressions, change in facial appearance, difficulty in opening his mouth, darkening of the skin, dry, scaly, thickened skin over the palms and soles. Scales were white, tightly adherent. He complained of intermittent itching over both lower legs with no specific time of occurrence and no family history of similar symptoms. There was loss of hair from the lateral aspects of both eyebrows and axilla. He also noticed changes in nails. He experienced redness over the face, hands, and feet, occurring within 15 to 30 minutes of sun exposure and resolving approx after 30 minutes of seeking shade. Hence, his quality of life and job are significantly affected. There is no history of papule, nodule, sparse pubic hair, and discoloration of digits on cold exposure. Pesticide exposure, dryness of eyes and mouth, swelling on neck, upper back, shoulders, scalp. Feeding of rapeseed oil, use of drugs, IV contrast. Puffiness of face, burning sensation in throat. Systemic history was unremarkable, except he has history of pain in small joints of hands. Past medical, past surgical, drug history, transfusion history, allergic history was unremarkable. He was addicted to MAVA since childhood. Rest of the personal history was normal. No similar skin disease in family. He lives in well-ventilated, rented house, consists of 2 rooms, use tap water, low socioeconomic status. Now moving towards the examination, a middle-aged man of average height and build, well-oriented to time, place, and person, was sitting comfortably on bed. He was vitally stable. Some vitals were normal. Moving towards the cutaneous examination, diffuse thickening, shiny, and indurated skin over the face, neck, trunk, bilateral upper limbs, palms, soles, and lower limbs. Axillary and genital regions were spared. Reduced facial expression due to skin stiffness as shown in this picture. Prominent horizontal furrows over the forehead and longitudinal furrows over the glabella, leading to an early leonine phase. Here you can see in this picture, multiple pitted box scars and lateral medullary can also be appreciated. Similar changes over periauricular areas. Reduced interincisal distance of approximately 3 cm. Mobility of lips and mouth is decreased due to skin thickening and induration. Multiple longitudinal furrows are noted over the bilateral shoulder regions, upper spinal area, nape of the neck, consistent with the sharp eye sign. Hyperpigmentation can also be appreciated over the back. Here you can appreciate better. Criss-cross pattern is consistent with cutis rhomboidalis leuci. Similar changes can be appreciated over neck, axillary region, bilateral cubital fossa, and axillary folds. Diffuse hyperpigmentation is observed over the bilateral elbow areas with mild, fine gray color scaling. Skin of the bilateral hands appears thickened, shiny, waxy, and indurated, extending up to the wrist joint. Marked thickening of skin over the dorsum of the both hands, resulting in distal tapering of the fingers. Restricted movement is noted at the interphalangeal joints involving flexion deformities. Here you can see in this picture, and contractures of the proximal interphalangeal joints, more prominent over the left dorsum of the hand. Peeling of skin in interdigital web spaces of left dorsum of the hand. Fine white scales were observed over the palmar aspect of the bilateral hands, more prominent over the left hand, with resorption of the distal phalanges, contributing to shortening of the fingertips. Similar changes over legs anteriorly as well as posteriorly. Plantar skin appears thickened and firm with white fine scales. Pigmentation is noted over the molar and premolar teeth, likely secondary to arecanut use. Nails are dystrophic with subungual hyperkeratosis and subungual hypertrophy and hyperkeratosis over the left hand, while longitudinal ridging and yellowish staining of nails over the right hand. Toenails show no specific dystrophic changes. Now moving towards the musculoskeletal examination. Flexion contractures at proximal interphalangeal joint and distal interphalangeal joints are noted with restricted movement at metacarpophalangeal joint and interphalangeal joints without tenderness. Flexion deformities and restricted movements were also noted at proximal interphalangeal joints of toes. Rest of the musculoskeletal examination was unremarkable, except prayer sign and inverse prayer sign. Which was positive. Schober test was normal. Systemic examinations, including neurological, cardiovascular, respiratory, abdominal examination, was unremarkable. Now, the case summary. 38 years old male laborer presented with a 9-month history of progressive skin tightening involving the hands and feet, later extending to the limbs, face, neck, and trunk, sparing the axillae and genitalia. With stiffness of fingers, limited joint mobility, reduced facial expressions, and difficulty in opening of mouth. Dry, scaly skin over palms and soles, itching over the legs, hyperpigmentation, nail changes. He had a sclerodermite facies, early leonine appearance, with deep forehead furrows and indurated waxy skin involving the face, trunk, limbs, palms, and soles. Sharper sign and cutis rhomboidalis nuclei are present. Flexion contractures at interphalangeal joints of fingers and toes are present with restricted range of motion. Palmar and plantar scaling was prominent with digital pulp resorption. After the complete history and detailed clinical examination, we came up with the differential diagnosis based upon features of our patient. So our first differential is scleromyxedema. Other differentials are scleroedema, pseudoscleroderma, and diffuse systemic sclerosis. To rule out the final diagnosis, we go through some baseline investigations, including hematology, biochemistry, liver function test. All were normal. Vitamin D was deficient, which was 9.28, while lipid profile, thyroid profile, viral markers, autoimmune workup was normal. Urine examination shows occult blood positive with 4 to 6 red cells. Leukocytes and epithelial cells were occasionally found. While urine culture and sensitivity shows no growth, urine biochemistry, ultrasound KUB, prostate, ultrasound abdomen was normal. Fungal scraping of nail was positive. Skin incisional biopsy was done that shows skin covered tissue showing basket V keratosis with thinning of red ridges, along with focal melanin incontinence. The underlying dermis shows increased number of spindle fibroblasts in the reticular dermis, along with the mucin. Mild lymphoplasmacytic infiltrate is also noted. So features are consistent with scleromyxedema. As scleromyxedema is frequently associated with monoclonal gammopathy, so we go for serum protein electrophoresis with immunofixation. That shows monoclonal peak in gamma region indicative of monoclonal gammopathy, with immunoglobulin G and lambda light chain. Is multiple myeloma is almost always preceded by monoclonal gammopathy of unknown significance, and patient had an increased risk of any non-traumatic fracture, but higher for skull, vertebral, pelvis, and sternum. So we go for a skeletal survey, but a skeletal survey was unremarkable for non-traumatic fractures and lytic lesions. Although a skeletal survey with plain radiography was used to assess bone involvement, but whole body low dose CT alone or in combination with PET has proved significantly more sensitive and is currently recommended by International Myeloma Working Group. So we go for PET scan as well to see bone and other tissue involvement, and it came out to be unremarkable. Now, plan is to repeat serum protein electrophoresis after 3 months to exclude early myeloma. So, based on clinical and pathological correlation, we came up with a final diagnosis of ischemic edema associated with monoclonal gammopathy of undetermined significance. Points which are in favor of ischemic edema are patient's skin is sclerodermite in appearance. He had leonine face, sharp eye sign, sparse eyebrow hairs, reduced mobility of mouth, joints of hands and feet. Histopathology finding favors the diagnosis. It was associated with monoclonal gammopathy. Thyroid function test was normal and mucosa were not involved. So we counseled the patient in detail regarding the nature of the disease. We advised him to avoid sun exposure and some exercise as well. These are 5 steps of exercise for the face and mouth. Here you can see in the picture. These are for the hands. We started low dose of tablet thalidomide 50 mg once in a day. He continued undergoing physical therapy and receiving emollients. Urology review and nephrology review was taken on board for deranged UDR. They advised to hydrate the patient as sport PCR, renal function test, and ultrasound KOB was normal. These are comparative changes before and after taking 2 months of approximately 2 months of tablet thalidomide. Patient tolerated thalidomide well. He experienced mild drowsiness but denied other adverse effects, including paresthesias. Patient began to notice decrease in duration and increased mobility. He quickly showed signs of improvement. Let's have a brief discussion about the disease. Scleromyxedema is actually a variant of lichen myxedematous. Characterized by mucin deposition, it was associated with monoclonal gammopathy with systemic implications. Equal incidence were reported in male and female. Pride of histopathology findings include diffuse mucin deposition, increase in collagen deposition, and fibroblast proliferation with normal or thin epidermis. Clinical features include linearly arranged papular eruption. This is the leonine face, sharp eye sign, donut sign. These are other clinical features. These are the complications and comorbidities, including monoclonal gammopathy, carpal tunnel syndrome, inflammatory myopathy, congestive heart failure, dysphagia, acute renal failure. Course and prognosis is variable, chronic, progressive, and sometimes unpredictable. Treatment ladders include first line is IV immunoglobulin, second line is thalidomide, systemic steroids, both commonly used in combination with IV immunoglobulin rather than as monotherapy. And third line include autologous peripheral blood stem cell transplantation. Here are some other management options. So now coming to the literature review. This is the case report in which patient was given tablet thalidomide 100 mg once in a day and improvement was noticed within 6 months. This article also highlights that scleromyxedema can also present as scleroderma without papules. I would like to end this case with take-home message. While scleroderma is a rare and challenging condition, early diagnosis, ongoing medical care, and a multidisciplinary approach can help manage symptoms, prevent complications, and improve quality of life. Thank you. Now I would like to invite our next presenter, Dr. Sumaya Shakil Ahmed, for an
मेरे पास तो नहीं आ रहा।
Assalamu alaikum. I'm Dr. Sumaya Shakil Ahmed, postgraduate trainee in the Dermatology Department of Jinnah Postgraduate Medical Center, Karachi. And today I'm going to discuss another interesting case that reported in our ward in this clinicopathological conference. This is the biodata of my patient. 29-year-old female patient, married, housewife, resident of Shikarpur, known case of diabetes, admitted in dermatology ward with the presenting complaint of multiple red to violaceous painless nodular lesions all over the body since a year. She was all right 1 year back when she developed pea-sized flat red lesion at the left elbow, which increased in size and became pea-sized swelling in a period of 3 days. It continued to increase in size in next 9 months and became bowl-sized red to violaceous nodule. This swelling was associated with mild itching, occurred intermittently but not associated with any pain, discharge, ulceration, or swelling of affected limb. It didn't cause any restriction of the movement at the left elbow joint except discomfort. After 9 months, she developed similar nodular lesion with similar pattern of progression at the right cheek, then on left cheek, left leg, thigh, chest, spearing abdomen, palms, soles, right leg, back, and genital area within a period of 3 months. Lesions were persistent. She lost 7 kgs of weight within a period of 9 months without any dietary changes. She complained of multiple lumps at the mandibular area and the neck, which were not associated with pain, discharge, or any surface changes. Gradually, their size increased, and patient developed difficulty in breathing and swallowing for the solid food at the level of upper neck due to the pressure effects. Swellings of the face were obscuring her visual field as well. She recently developed multiple bruises at the chest and back spontaneously without any trauma. There was no history of redness all over the body, thickening of palms and soles, blisters, hypopigmented or hyperpigmented lesions. No history of headache, seizure, confusion, any eye symptoms, palpitation, syncope, chest pain, small joint pain, photosensitivity, oral ulcers, Raynaud phenomena, muscle weakness, skin thickening, heat or cold intolerance. No bleeding from any side, no hair and nail changes or mucosal lesion. For these complaints, she went to the hospital where certain medications, including antibiotics, were given, but no improvement. Due to these lesions, patient has difficulty in social interaction and disturbed mental health, as well as leading to mood swings, depression, and anxiety. In systemic inquiry, history of malaise and myalgia were present, while the rest of inquiry were unremarkable. Personal history shows normal appetite, disturbed sleep, history of weight loss as described previously, normal bowel and bladder habit. Addiction history and menstrual history were unremarkable. In past medical history, having diabetes on oral hypoglycemic since 4 years, diagnosed when routine blood test was done for screening. Past surgical, transfusion, and travel history were unremarkable. Family history, 3 siblings, 2 brothers, and 1 sister. All are healthy, alive, mother and father alive. History of pulmonary TB in the father, which was treated. No history of similar illness or the skin disease in the family. Drug history. During course of illness, she has taken multiple analgesics, antibiotics, recently taking tablet coamoxiclair, clavulanic acid 625 mg TDS, tablet dapagliflozin 10 mg OD, tablet moxifloxacin 400 mg OD, and the mupirocin ointment. Socioeconomic history. Patient belonged to the middle class family. In the general physical examination of the patient, young female of average height and obese, well-oriented with time, place, and person, lying on bed comfortably, well cooperative throughout the examination. Her vitals were BP 130 by 80 millimeter of mercury, pulse 75 beats per minute, temperature 98 Fahrenheit, respiratory rate 20 beats per minute. Her sub-vitals were Pellarnis positive. In the lymph nodes, multiple bilateral, submental, submandibular, anterior cervical, preauricular, and postauricular median group of axillary lymph node were palpable. Most of were 1.5 into 1 centimeter, matted non-tender. Multiple bilateral inguinal lymph nodes palpable, which were of similar morphology, matted, tender, 6 centimeter in diameter. On cutaneous examination of the patient, there were multiple well-demarcated erythematous to violaceous nodules of variable size and shape present bilaterally at the forearms, cheeks, breast, thighs, and left leg. Largest nodule present at the extensor surface of the left forearm near the elbow joint, measuring about 11.5 into 6.5 centimeter. Surface of the nodule was smooth, erythematous to violaceous with ecchymotic changes. It was non-tender, firm in consistency, slightly warm than the surrounding skin, non-adherent to the underlying structures. Well-demarcated ulcer secondary to incisional biopsy is also appreciated on the surface. Surrounding skin appears normal. Regional lymph nodes not appreciable. There are 3 well-demarcated nodules present on the bilateral cheek which were of similar morphology and surface was rough. 2 at the right cheek and 1 at the left cheek that were obscuring her visual field. There are multiple violaceous patches and round, well-demarcated, scaly indurated plaques with regular borders scattered on the bilateral thighs, largest plaque measuring about 3 into 4 centimeter on anterior side of the left thigh and induration measures about 2.5 into 3 centimeter associated with the scales which were sparse, thin and gray color. There are multiple ecchymosis and violaceous nodules and plaques appreciated at bilateral breast and flagellate erythema and bruises at the back. Hair examination was normal. Nails containing right big toe contained the Bu's line. Oral cavity was normal. Endoscopy was negative and DLQI of the patient was 19. Systemic examination of the patient was unremarkable. On the basis of the history and clinical examination, our differential diagnosis were, our first differential diagnosis was primary cutaneous B-cell lymphoma, tumoral MF, primary cutaneous peripheral T-cell lymphoma, leukemia cutis, cutaneous metastasis, nodular sarcoidosis, Kaposi sarcoma. Going towards the investigation of the patient, patient's complete blood count shows pancytopenia, lymphocytosis, and neutropenia. HB was 6.7, platelet 134, WBC 3.5, neutrophil 13, lymphocytes 69.3. In other labs, CRP 63, ESR 125, LDH was 440, albumin 3.3, HbA1c was 7.2, while the rest of the investigations were unremarkable, including urea creatinine, viral marker, TSH, urine DR, lipid profile, and chest X-ray. Ultrasound abdomen shows hepatomegaly of 19 centimeters, splenomegaly of 14 centimeters, few renal microliths at the right side. Ultrasound pelvis was normal. X-ray left elbow was unremarkable. MRI left elbow shows neoplastic mass or neurogenic tumor. FNAC report of the left elbow lesion shows atypical mononuclear cells with enlarged nuclei, scanty cytoplasm, LCA positive. Histopathology report of the patient shows neoplastic lesions arranged in the form of sheets, small to intermediate size, moderate amount of cytoplasm, vesicular to hyperchromatic nuclei with inconspicuous nucleoli, frequent mitosis, surface epidermis is uninvolved. Immunohistochemical stain in the neoplastic cells shows LCA, CD99, 43, Ki67, BCL2, TDT were positive, while the rest of the markers were negative. Overall features favor acute T lymphoblastic lymphoma. These are the PET scan images of the patient. PET scan report shows FDG positive lymphadenopathy on either side of diaphragm with the involvement of nasopharynx, palatine tonsils, face, spleen, breast, bone marrow infiltration. Oncology was taken on board and they advised for the bone marrow biopsy and cytogenetics to rule out the leukemia, and to reduce the tumor burden, cyclophosphamide was started. Immunophenotyping of bone marrow shows CD4 51%, CD33 21%, HLA-DR 54%, CD45 54%, CD117 20%, CD36 51%. Overall shows positivity to the myeloid cell CD33 with HLA-DR positive. Immunophenotyping of the bone marrow favors acute myeloid leukemia. From dermatology department, patient was referred to the oncology as bone marrow biopsy and immunophenotyping shows acute myeloid leukemia. So again, the second review was carried out extensively by the board of pathologists. Second, skin biopsy for the histopathology and immunohistochemistry was done again. And this is the block and slide review. Second opinion, which shows superficial and deep dermis diffusely infiltrated by the shields of immature neoplastic cells. Blastoid morphology. Neoplastic cells are intermediate in size, uniform, hyperchromatic nuclei, inconspicuous nucleoli, moderate to scanty cytoplasm, mitosis in the lesion. Immunohistochemical stain shows LCA, CD4, CD56, TDT positive, Ki67 70 to 80%, CD3 was negative. Based on immunohistochemical and flow cytometry report, features favors blastic plasmacytoid dendritic cell neoplasm. This is the second skin histopathology. Papillomatosis, unremarkable epidermis. Dermis shows perivascular periadinaxal lymphocytic infiltrates, brain zone seen between the epidermis and the dermis. Immunohistochemical stain shows reactive pattern for the CD20, CD3, and Ki65, while the rest of the markers were negative. Conclusion: skin covered tissue showing reactive inflammatory infiltrates, and they follow the opinion of the block and slide review. On the basis of the clinical findings and the histopathology report, we came to the conclusion of the final diagnosis of blastic plasmacytoid dendritic cell neoplasm with cutaneous and leukemic involvement, one of the rare tumors of the skin. This is the picture of the patient before the getting treatment and after starting on a CHOP therapy. Despite of the CHOP therapy and palliative measures, patient condition got worse and she passed away. This is the topic of the disease, which I'm now going to discuss. Blastic plasmacytoid dendritic cell neoplasm, CD4 positive, CD56 positive hematodermic neoplasm. It's a rare hematodermic neoplasm, represents 0.7% of the primary cutaneous malignancies, derived from plasmacytoid dendritic cells, predilection for the extranodal sites, particularly skin, and a tendency to leukemic dissemination. Previously, this tumor was thought to be derived from NK cells because of CD56 expression. Age of the patient, most common 65 to 67 years, gender male predominance, and it is associated with the myelodysplasias and myeloid malignancies. Pathology shows dense monomorphic infiltrates of medium-sized tumors with a fine chromatin resembling lymphoblast is seen throughout the dermis, with a well-defined grain zone. This is the histopathology picture that shows the grain zones and dense atypical mononuclear cell in dermis. And this is the more closer view that shows large atypical mononuclear cells. Immunophenotyping shows tumor cells are CD56 positive, CD2, 7, and cytoplasmic CD3 are usually negative. CD123 and TCL1A confirms the diagnosis. CXCL12 indicates a potential for the leukemic dissemination. Clinical features: multiple and rarely solitary large dusky mauve dermal tumors. Upper trunk is often affected. Lymphadenopathy, peripheral blood, and bone marrow involvement is common. This is the pictures of the patient that shows the multiple mauve-colored dermal tumors scattered throughout the chest. Another picture showing the similar nodules at the different parts of the body. Another pictures of a patient. Course and prognosis. The prognosis is poor with a median survival of 14 months. Management. There's a different management options. Combination chemotherapy and radiotherapy can produce a partial remission, which is invariably short-lived. Myeloid leukemia protocols, stem cell transplantation, and tagroxofus, which is a fusion protein made up of interleukin-3 and diphtheria toxin. It acts on the CD123 receptors and inhibit that. And it's a US FDA approved for the use in the adult and children older than the 2 years for the initial treatment of blastic plasmacytoid dendritic cell neoplasm or relapsed cases and in the recurrent cases as well. And now I want to conclude my presentation on this take-home message that early recognition and timely treatment of the disease is not just a clinical responsibility, but a moral imperative. Vigilance, compassion, and swift action can save lives. Thank you so much. Now, I would like to invite my third presenter for another interesting case, Dr. Mary Meher.
Assalamualaikum everyone. I am Dr. Mary Meher, working as a postgraduate resident at Department of Dermatology, JPMC Karachi. I am here to present a case of 25 years old male, unmarried, policeman by occupation, no any comorbid, resident of Sultanabad, admit through OPD with the presenting complaint of joint pain for 18 months and red raised scaly lesions all over the body for 3 months. The patient reports that he was in usual state of health 18 months back when he developed joint pain involving bilateral knee joint. Gradual in onset, moderate in intensity, graded as 7 on 10 on severity scale, aggravated on walking, and temporary relief by taking painkillers. Not associated with redness, swelling, and restriction of movement. No history of small joint pain, morning stiffness, and swelling. For this complaint, he visited rheumatologist who prescribed him tablet methotrexate 10 mg weekly, tablet folic acid 5 mg daily, and tablet betadine 45 mg daily, and then tapered off. His symptoms improved with these medicines. He took tablet metho for 8 months. but discontinued on his doctor's advice due to gastrointestinal upset. For the last 3 months, he developed erythematous raised scaly lesions over genital area and scalp that gradually increase in number and size to involve bilateral upper and lower limbs, trunk, face, palms, and soles over a period of 1 month, sparing bilateral axilla. The lesions were associated with itching with no specific time of occurrence, graded as 7 by 10 on severity scale. Family history of itch was negative. The lesions were covered with yellow scales that are tightly adherent to the skin, approximately a fistful in quantity. Upon removal of scale by scratching, a pinpoint bleeding was observed. Along with these lesions, the patient also complains of pain in the left knee joint and lower back. Gradual in onset, severe in nature, graded as 9 by 10 on severity scale, and patient was unable to walk. Exacerbated by walking, climbing stairs, and prolonged sitting, and temporary relief by medications and lying down. Associated with the redness, swelling, and restriction of movement in the affected joints. Patient has positive history of unintentional weight loss of about 10 kg over a period of 1 month. On further inquiry, he also complained of nail shedding of all toes twice during this period. Patient denied any history of photosensitivity, oral or genital ulcer, finger discoloration, heat or cold intolerance, fever, cough, night sweats, lumps or bumps in the body, burning micturition, urinary urgency or frequency, eye symptoms like redness, pain or vision changes, difficulty in combing hair, standing up from sitting position, difficulty in chewing, opening of mouth and facial pain, abdominal pain, diarrhea and constipation, headache, swelling lymph nodes, any traveling history, and Hakimi medications. Systemic inquiry was unremarkable other than the presenting complaints that are already described. Patient has history of pulmonary TB twice in the childhood for which he took treatment for 9 months. Patient underwent surgery for anal fissure 2 years back. Personal history was unremarkable except for the disturbed sleep. He took tablet methotrexate, folic acid, and betnilan and various topical ointments for 8 to 12 months. His allergic history, transfusion history, family and socioeconomic history all were unremarkable. On general physical examination, a young male of average height, weight, and build lying uncomfortably on the bed due to pain, well oriented to time, place, and person with normal vitals. Except for the pallar, rest of the subvitals were normal. On cutaneous examination, there were multiple well-defined erythematous scaly plaques of variable size and shapes predominantly over the scalp, face, trunk, bilateral upper and lower extremities, groin area, palms and soles, sparing bilateral axilla. The largest plaque was present over the trunk, measuring size about 16 by 10 centimeter. The scales were thick, yellow in color and firmly adherent. Plaques were non-tender and temperature gradient was negative, auspic sign positive. Papules and plaques of similar morphology also present over forehead, cheeks and perioral region, anterior and posterior aspect of the forearm and across the back. Papules and plaques of similar morphology were also present over groin area. Some were scattered and some were coalescing to form large plaque covered with thick adherent yellowish crust. No oozing or discharge noticed. There were multiple discrete erythematous scaly papules and plaques. Some were annular and some were circinate present over the palms. Scales were thick, yellow and non-greasy. These findings were consistent with keratoderma blanorhizicum. There were thick yellowish keratoderma on background erythema with some areas of fissuring over bilateral soles. Lesions of similar morphology can also be appreciated over dorsal and lateral aspects of the feet. Scalp was covered with the thick scales. Poor oral hygiene. There was a erythematous scaly plaque present over the sharp and glans penis. Scales were thick and yellow. No purulent discharge noticed. dystrophic, yellow, broken, crumbled nails of all toes. There is anonychia of right big toe, increased transfer curvature of the nail, and subungual hyperkeratosis of the left big toe. Onychogyrophosis of left, third, fourth, and fifth toe. On musculoskeletal examination, there was a swelling and redness over the left knee joint. All other joints were normal. Temperature gradient was positive over the left knee joint and it was tender untouched. Fluctuation test was positive over left knee joint. There was a restricted range of motion of left knee joint with painful active and passive flexion and extension. Gait was antalgic. Schober sign negative. Faber sign was positive. Temporomandibular joint and cervical movement were normal. On abdominal examination, liver was palpable 2 cm below the right costal margin. Rest of the examination was unremarkable. On respiratory examination, there was a dull percussion note on the right side and fine inspiratory cracks were present over right mid and lower zone. Cardiovascular examination and neurological examination was normal. Based on the history and clinical examination, my differential diagnoses are reactive arthritis, plaque psoriasis with psoriatic arthritis, secondary syphilis, and septic arthritis. On investigation, his HP was 10.1, MCV 75.3, urea create electrolytes, LFTs, thyroid profile was normal, iron was reduced, and ferritin was highly raised. His viral markers, including HIV, were negative, ESR and CRP highly raised, ASO titers and R effector were negative. Lipid profile, vitamin D, uric acid, all were normal. Ultrasound abdomen shows hepatomegaly, right renal microliths, and right-sided pleural effusion. So we get X-ray test done that was unremarkable and pulmonary department was taken on board. They advised HRCT, Montauk's test and IGRA, all were unremarkable. If there was a swelling of left knee joint, so X-ray of the knee joint was done that shows the soft tissue swelling and rheumatology department was taken on board. They advised synovial fluid DR that shows WBC count 12,160, synovial fluid CS that shows no growth, X-ray sacroiliac joint that was unremarkable, and MRI sacroiliac joint shows the finding of bilateral sacroiliitis. X-ray hands were normal, DEXA scan normal, urine DR and CS was normal, nail clipping for fungal element shows no growth, skin biopsy was done that shows acanthosis, hyperkeratosis, parakeratosis, Monroe's abscess, and neutrophilic abscess as you can see in this slide. Actually, B27 was positive. Considering patient's age, skin finding like keratoderma blenuragicum and sarcinate balanitis, MRI finding, and positive HLA-B27, we diagnosed him as a reactive arthritis. For joint mobility, he was advised physiotherapy along with specific treatments such as injection methotrexate and NSAIDs like COX-2 inhibitors, and he was discharged on the same treatment which was given in the ward. Now you can see the improvement after 1.5 months. Now let's see the topic discussion. Reactive arthritis, formerly termed Ritter syndrome, is an autoimmune condition that develops in response to an infection, mostly gastrointestinal and genitourinary. Cases of reactive arthritis following COVID-19 infection has been reported. The classic triad is non-infectious urethritis, arthritis, and conjunctivitis. Some add a fourth component that is mucocutaneous finding to make up a diagnostic tetrad. Histopathology findings are same as in psoriasis. Treatment include NSAIDs. They are the mainstay of therapy, corticosteroids, antibiotics, DMARDs, physical therapy, and the treatment of cutaneous disease include the topical therapy that include topical steroid and calcipotriol. phototherapy, methotrexate, and biologic agents. Reactive arthritis is usually a self-limited condition and carries a good prognosis. But those who are HLA-B27 positive may develop a chronic course longer than 1 year. Now I will conclude my presentation by take-home message that soles, nails, eyes, and mouth. Reactive arthritis leaves clues everywhere. Now I will call our worthy supervisor, Professor Dr. Rabia Ghafoor. Please come and give comments on all three presentations.
Thank you so much. This is the 22nd CPC. As you all know that we are doing monthly CPCs for last 2 years now, more than 2 years now, and each institute of Karachi actively participates in these CPCs and brings very interesting cases for learning of everybody, for consultants and for postgraduate students and other interested dermatologists also. So we are little running out of time. We presented 3 cases, and all 3 were gray cases. The first case was scleromyxedema, which is very rare case, and we see very few cases in our whole career of this patient. You have to keep a high index of suspicion. It should be worked up completely, extensively for underlying cause, as our case was associated with the monoclonal gammopathy of insignificance, of no significance, and but these cases has to be treated and should be monitored for complications, because later on may develop some complications. Second case was a real great case for us all, and oncology as well, and for histopathologists and as well. We did biopsy twice, and the final diagnosis was a blastoid plasmacytoid dendritic cell tumor, which is a very rare neoplasm and with a very poor prognosis. Unfortunately, our patient passed away in like 2 months. Third case was reactive arthritis. Reactive arthritis is a very rare condition. Psoriatic arthritis is more common, and there is they are more the differential diagnosis lies between these two types of these two conditions. In reactive arthritis, the arthritis is mostly seen in young males. Typical clinical features, skin features, and HLA-B27 positivity. Then the more involvement of lower limbs. These features suggest the diagnosis of reactive arthritis. And this patient came to us on wheelchair and went back at home on his walking on his foot. So properly diagnosing and properly counseling the patients and giving appropriate treatments bring changes to the patient's life of dermatological patients. Now we have Dr. Javed Memon, who is President, Pakistan Association of Dermatologists. I will like to have some reviews from him. Any other questions are also welcome. You can ask in the chat box.
Bismillahirrahmanirrahim. Thank you, Dr. Rabia Ghafoor, for the excellent presentation from your department. It's really great efforts by all HODs of the teaching institute who brought us the great, the case presentations, because mostly these are missed by even the senior dermatologists who has no teaching institute or the indoor setup. What I want to suggest here, that this type of these CMEs and CPCs should be conducted all over the Pakistan, not only in the Karachi, because the Hyderabad, Larkana, Lahore, they have so many patients like that, which may be missed or which not be bring in this you can say the large forum. So I request Mr. Yasir Mubarak and the all HODs. Even we can present all these previous cases in a big summit, like we can arrange the big conference for this, because these are very important. And second one thing is that we should have some follow-up system, because without the follow-up system, it's not possible to get the patient situation. Sometimes they come here and they become very well and go back to the home. So we should not miss the patient. So this is my suggestion. I really impressed with the all you people who are doing the best for the dermatologists. Even uh, we are not able at the early stage to diagnose, even after the final diagnosis. This is very important. I think this should be continue for the many years. Thank you.
Thank you, Dr. Javed. Now, Dr. Humaira Talat, she wants to comment. Dr. Humaira?
Assalamu alaikum. Assalamu alaikum, everyone. Can you hear me?
Yes.
First, I would like to congratulate Dr. Rabia Kapoor and her team for bringing these wonderful cases. All the cases were wonderful and well explained and well presented. Thank you so much, Dr. Rabia. And from your platform also, as Dr. Javed, he has mentioned that we would like to invite other hospitals also to please come forward and bring their own cases, and we are ready to help them in that regard also, because being part of civil hospital and as Dr. Rabia Ghafoor is part of JPMC, we have been receiving patients not only from all over the Sindh but also from parts of Balochistan and Punjab. So we would appreciate if other hospitals would come forward and would participate in this CPC meeting. Thank you, Rabia, for all these well worked up cases. Thank you so much.
Thank you so much, Dr. Humaira, and thank you everyone who connected to us in this morning and took interest in our activity. Thank you so much.